This is one of several videos that we're going to talk about in a series where we specifically address end-of-life symptoms. And today we're going to be focusing on the lungs specifically. Hi, my name is Abigail. I'm here to normalize these conversations and education about death and dying so we die better at end of life. Let's get into it today. There are, as you maybe can imagine, there are so many symptoms that can pop up at end of life. We talked about the dying body and how and if I haven't posted it yet, it will be coming, about expecting the unexpected, that just things happen, especially in a dying body, because a dying body is extremely fragile. And in this state of fragility, it's experiencing things like multiple organ failure and continued decline of all these other system processes that impact its ability to continue living. So the dying body will do things unexpectedly, will develop certain symptoms at end of life for which we always need to be prepared. And this is why, again, I always say, make sure that you have hospice care for yourself or your loved one when, determined to be terminal, because you really need all these resources in place, having your medications, having your plans in place when these symptoms pop up. Can we predict all of them? We can predict many, but we can't predict all of them, and this is why you want to have hospice care, especially to help you predict them and also deal with the symptoms that pop up when they come out of the blue, it seems. But again, when you're working with a hospice team, they should always be properly prepared for that. Today, I want to talk and focus solely on the lungs, okay? I kind of like to break the body into certain areas like head, chest, things like that. I'm going to start with part of the chest right now and just focus on the lungs and kind of the symptoms and the stuff that you'll see at end of life in terms of end of life symptoms that may pop up. The most common end of life symptom that pops up when it comes to breathing, and breathing in particular, is these different types of breathing patterns that happen. And I will try to keep it as simple as possible, but one of the more common things that I have seen in my experience is things like respiratory distress that pop up right before the person may die, and it can last anywhere from minutes to days to weeks. And especially if someone already has like a diagnosis like of chronic obstructive pulmonary disease, lung cancer, things like that, or something that impacts the lungs like congestive heart failure, because that can, do things like cause fluid in the lungs, things like having a severe, serious liver disease or abdominal types of cancers, things like that cause the abdominal area to become distended, to become bigger. And what that does is it pushes that diaphragm up and keeps those lungs then from being able to expand totally, because your diaphragm is like kind of a dome like this. And when you take a deep breath in, it actually flattens. Okay, so when you take a deep breath in, it flattens, and what that does is it actually pops those lungs up and expands them a little bit more. So this is why, like when you've done a tough workout or, you're trying to catch your breath, you might do something called a tripod position. You might sit in your seat and kind of lean forward like this and try to catch your breath, or you might stand up. And then for podcasting, I'm showing on the video, you kind of stand up and you kind of lean forward like this and try to catch your breath. So we see, in my experience, I saw a lot of, patients with these lung issues. You'd see them do variations of this tripod pose because they were trying to aid their lungs in expanding a little bit more because they had these other issues going on with them. So respiratory distress is a very, very common symptom. What does it mean? It means that you're breathing usually uncomfortably, and we got to do something about it. So it could look like someone is just breathing a little bit faster than normal, or it could be a lot faster than normal. And it could be also with minimal effort or with some more extensive effort. So what is faster than normal? Well, you really want to look at what's kind of the baseline for the person who is experiencing this respiratory distress. In the medical books, typically a normal respiratory pattern is anywhere from 12 to 18 to 20 breaths per minute. But if you have had a person who has had COPD or asthma or lung disease for a really, really long time, their normal baseline rate could be like 24 to 26 breaths per minute. So you don't want to try to aim for something that is lower than what the normal baseline is. So whatever it is, they're breathing faster than their baseline, and it could be something like that. It could kind of sound like that, or it could be very, very shallow and very, very quickly. And usually there's some of effort involved. And by effort, I mean you see other parts of the body working to help that person breathe. So it could be as little as taking really, having a lot of motion in the chest, to using the abdomen to try to breathe, to using these neck muscles and seeing someone try to use all the muscles in their chest, their neck, and their abdomen to try to make them breathe better and try to get, because they're experiencing air hunger. They're experiencing hunger for more oxygen, and they're trying to use any strength they have in their body, even without knowing it, to try to capture some more oxygen so they can breathe easier. And in this too, you may have some other types of other signs that tell you, sometimes maybe the hospice nurse may come in and test the oxygen level. We're not trying to fix that oxygen level. That's just another point of information to tell us how severe this shortness of breath may be. For someone with, again, previous lung disease, that oxygen number may already be kind of on the lower end because, again, they've had a long-standing history of lung disease. But for someone who maybe didn't, and all of a sudden they're developing shortness of breath and they're showing low oxygen numbers with symptoms, that's telling us that, again, confirming that they might be a little bit more, they're experiencing this a little bit differently than a person who already has lung disease. And we have to treat these and in mind with what the baseline of this person is and keep that in mind for the treatment plan. These other types of symptoms, can also, you'll notice that the clinicians may also do things like listen to the lungs, and they may listen for what we are called clinically as adventitious breath sounds. These are breath sounds that are not supposed to be there. So they could sound like wheezing, and you may even hear wheezing without a stethoscope. They may sound like congestion. Again, you can hear congestion without the stethoscope. When someone is coughing, you can hear the congestion. You can even hear, when they're breathing, you may even hear like the congestion kind of in the back of the throat, which is also very common with and what I will be doing a video on too, is the death rattle. That's another thing for another day that we'll talk about in terms of end-of-life symptoms. But you can hear this congestion, you can hear the wheezing, you can see the effort with the breathing, you can see that they're breathing faster. A very, very typical type of symptom that we may see at end of life. This is something we can control. This is something with the right things in place, like with your emergency kit or e-kit. I did a video on those. They might already be in the home, and the hospice team can teach you how to do certain things to keep that person comfortable. From non-medications and non-pharmacologic type of standpoints, you can do things like elevate the head of the bed. If the person is already moving, if they're pretty mobile and moving already, you can teach them and get them into a tripod pose. Get something sturdy at the side of the bed and have them lean forward on it. Put them in a chair where their head is up, and a real sturdy table where they can put the front of their body, lean onto it more to help them expand their diaphragm. You can teach them how to do pursed lip breathing. It's very good for people with chronic obstructive pulmonary disease, asthma, and it's breathing where you have pursed lips and you kind of make a very small hole in your mouth like this, and it allows you to helps you with the balance of the CO2 and things like that a little bit more, and helps you breathe a little easier. Other things non-pharmacologically we can do, putting a fan on in the room. I know this sounds like, what? Opening a window, but having some kind of air motion is usually helpful. Or if somebody has allergies, making sure that those allergens are really well controlled in the house, having an air purifier, or getting a fan moving, or washing the sheets, things like that, or you just even taking the allergy medication, especially when it comes to things like, real allergy type of seasons. This really shouldn't impact you unless, someone is really, really sensitive, because if they're not going outside, they really shouldn't be experiencing too many strong allergies. But again, everybody's a little different. So those are things that you can kind of do from a non-pharmacological standpoint. When we talk about medications then, on a pharmacological standpoint, you can do things like, obviously oxygen is very helpful. Breathing treatments are very helpful. They are just held in on a mask, and you, while the breathing treatment's going, the person can just be breathing comfortably and regularly. And this is different than the inhalers. Inhalers where you have to, spray the inhaler medication in your mouth and hold it for a certain amount of time. I have seen mostly in hospice care that these inhalers become a little bit useless, not because they're bad medications, but because the person can't hold their breath any longer. And if you can't hold your breath for the allotted time that is required to take in the medication and actually absorb the medication, then they're not going to be as useful as they once were when you could hold their breath. So I would really talk to your, practitioners about this and see what's better for you. Most often, I would see that we would have to kind of switch these medications over to a regular nebulizer treatment, a breathing treatment that was just continuous, that could be held up with an oxygen mask. Someone could hold it up, or the patient could hold them up themselves if they were able to, and get a really good dose of medication to help keep their secretions a little bit mobile, a little thinner, to keep their lungs, their alveoli, all those parts in the lungs a little bit more open. So those things are very helpful. Other things, in addition to that, and oxygen, these treatments in oxygen, and there's obviously very, important things that we need to take care in terms of with oxygen safety. You can give medications, and this is where something like morphine, where people usually assume that morphine is right for end of life on a drip. No, this is where something like where morphine can be very helpful, because it can help open up the blood vessels a little bit more, relax the person a little bit more, and when you're relaxed, your diaphragm can relax a little bit more, your blood, vessels around your heart are a little bit more open, so blood is flowing a little bit more, and it's just generally a little bit of a relaxer. So a little touch of morphine can help a lot, even for somebody who is alert. You need to take precautions in terms of, risk for falls, especially, for the first timers using it. But I found it to be extremely helpful, especially for people with these lung issues that are also specifically tied to heart issues. So a little bit of morphine goes a long way. Not just used for the last day of life. Morphine can be very helpful even in palliative care before you get into hospice care for these types of respiratory issues. And other types of medications, whether it's something for anxiety or anything else that, that they're developing now for, better breathing and those types of things. But when we're talking about end of life, I do bring up the morphine. It is important to know that this is something that can be very, very helpful for for being able to breathe more comfortably and with lesser effort. So that is the gist there. I'm going to leave it at that. I know that we covered a lot, but let me know if you have questions, if you came across something that might have, that maybe I didn't mention that you'd like me to go into. I'm happy to do that. But those are just kind of the real basics when it comes to end-of-life symptoms in reference to the lungs, what you can see, and then what can be done about them from from not giving medications, so doing things outside of just giving medications, to interventions where we actually use medications and what typically we can use there. So hopefully you found this helpful. Let me know if you have questions or any, clarifications needed. Happy to do that. Thank you so much for joining. My name is Abigail. I'm here to normalize these conversations about education, and I'm here to normalize. My name is Abigail. I'm here to normalize these conversations and education about death and dying, so we die better end of life. Thank you so much for joining. I'll talk to you soon.